I will move to our last speaker, Daniel Engler.
Yeah. Hello. So, could you see my screen?
Yes, we do.
Okay, great. So now it can be better. Thank you for this opportunity to present the Affect.EU consortia. We started the project this year in January, and it's an EU-funded project for 3 years. Affect.EU is the short name. Called Digital Risk-Based Screening for Atrial Fibrillation in the European community. And this is initiated by Renate Schnabel. She's professor at the university here in Hamburg. I'm Daniel. I'm the project officer from this Affect.EU project. So just a little bit of background. Sorry. It's too sensitive. The Affect.EU background is AF is the most common cardiac arrhythmia in the European population. We already heard that. We know that the projection is that the disease will get a prevalence rate of up to 10 to 15% within 2060. And we know also that AF is often asymptomatic, but comes with a stroke, heart failure, or sudden death, and cardiovascular morbidity. So screening will be a much important target to tackle AF, and this is also a recommendation from the newest recommendation from 2020 for AF management. You see here in the upper line that we have an opportunistic screening for AF by pulse tracking or ICG rhythm stripe as a class 1 B1 level B recommendation. And also you see this new thing that is also one lead ICG devices are available in this. This is something new. So, but that comes to the question whom to screen and also how to screen, which device with which approach will be appropriate to screen population, and also the optimal setting for screening with highest efficiency. Is it within a clinical setting, or can it be in a population setting, or even can it be in a primary prevention setting? So these are the questions that came up. And for Europe, you can say that appropriate risk-based screening algorithm and systematic screening programs do not exist in none of the 26 European countries. So to tackle this, we want the Affect.EU objectives are, the major goal is to develop a risk-based AF screening algorithm using digital devices for early AF detection in the community. So the specific goals are the combining information from the largest outcome trials and the multiple screening studies across Europe. We have several clinical cohorts also on a larger scale or on a smaller scale, and we want to combine them. We want to identify high-risk populations within population-based studies who have an IF outcome data. We want to validate the Affect.EU risk-based screening recommendations that we will provide with the harmonized data set. And we want to demonstrate cost benefits and accessibility of AF screening with a meta-analysis on economics. We want to also identify the AF screening potential to be taken by differing healthcare systems, and we wanted to foster the dissemination of the FFDU results into the public. So first and the last thing will be if it's appropriate to adopt of the risk-based AF screening algorithm into guidelines. So when I talked about the consortium, the involvement of 26 partners are in place. So from 21 researchers, research fields, from nonprofit organizations, also from the industries, are in part of the consortium. So when we talk about the concept, we have 6 work packages, and the first work package will be the combining of well-powered large-scale clinical trial information to define the currently based AF screening strategy for implementations. That means also the integration of results from multiple smaller trials and clinical trials across Europe. And within, we have a data set and a phenotyping of over 300,000 screenees in clinical screening studies. Next slide will be to see this in the red frame are the involved participants or partners from the trials. It means we have the Danish Loop study. We have also the stroke stop 1 and stroke stop 2, a really large trial whose targeted systematic screening. We have the upcoming SAFER study is also involved, and the other clinical smaller trials will be also good, give us a good overview about the screener data we can have. So next thing, when we talk about the population-based studies, we wanted to bring this algorithm to refinement with a broader search of markers for risk stratification in the population to further improve the AF screening. This will be targeted by the Morgan cohort. It's a big Finnish data cohort within over 16 country population studies are involved in this. So we wanted also to refine AF prediction to increase accuracy and reduce the number needed to screen. And we want to measure anti-propanolide or any other biomarker in all studies within the available blood samples to also get a good target to measure biomarkers within screening strategies. You can see the community studies over here. We have on the one side the Morgan cohort, on the other side we have the Hamburg City Health Study, who involves 10,000 individuals with a really big data set, and is also involved in this. So this is the concept of work package number 2, the refinement. On the other hand, we wanted to have the meta-analysis and the systematic integration of evidence on the worldwide. So we took also other studies can add this data set if the harmonization process is cleared. So we want to bring the results of the similar clinical trials, and we want to aggregate to increase statistical power and provide robust endpoints. And we wanted to continue the collaboration of AF screening trials information worldwide over the AF Screening International Cooperation. So within the next work package, we also want to have a good outcome on health economics data and cost beneficiary on that. So that will be cost-beneficial analysis, will be guide the development and the refinement of the risk-based screening algorithm, and also serves as evaluation inequalities. And we wanted to compare costs of different AF screening devices. And we wanted to test also different screening modes, from opportunistic screening to systematic screening, from single time point screening to prolonged screening, and so on. And in the end, we wanted to underlying populations, for example, age strata or general practices. So we wanted to test it also in different settings. The last one will be also the dissemination of the results. That means the implementation of strategies include multifactorial stakeholders' inputs. That's what we're doing here right now, and also to want to get out of the research area, wanted to go into public with results. And the one thing is that we also wanted to implement interdisciplinary consortium conferences into screening, and we wanted to compile standardized survey on implementation changes and obstacles to see how can really a screening setting can be implemented, and know the obstacles of screenings and all chances, how can a screening really be integrated in a specific area, region. And this last slide show you how the concept will be in general. So we will build AF strategy of when we get into research. We had the clinical trials, we had the cohort studies. We want to analyze the currency, that we want to see the outcomes, the healthcare economics will be in place. We want to read programs. That will be a validation process with the design and refinement of the identification of risk groups, and also the stratification of health risk factors and the optimization of the strategy. And then we want to validate it and launch it, and to maintain and turn to the risk-based screening strategy. So that will be the iterative process of the development and the refinement of optimization risk-based screening strategy in general. So I wanted to thank you, and this is my team here in Hamburg, and I now get back to you.
Thank you very much, Daniel, for your presentation. There were the other presentations really interesting, and now we will start with a discussion in a roundtable. Let me first ask to Trudy Loban, what do you think is the patient's point of view of the management of atrial fibrillation in general?
The patient's point of view on the management of atrial fibrillation.
Yeah.
I think that for most patients, they don't know, because atrial fibrillation isn't one of those public illnesses, diseases, conditions that most people, the first time they've ever heard of AF is when they're diagnosed with it. So it then becomes an absolutely minefield as to who, what, why, where to go. And I think that's why when I founded Arrhythmia Alliance back in 2004, 51% of our inquiries to Arrhythmia Alliance were AF related. And at the time, John Cam and I searched, and there were no other organisations offering information, support, education, awareness on AF. Fast forward 13 years, obviously there's a lot more information on AF, but there's still a lot more to do. And we need to get the public as aware of their heart rhythm as they are of their blood pressure, their cholesterol, their weight, symptoms of stroke. We don't want AF patients to have symptoms of stroke. We want AF patients to make sure that their AF is being managed, they're being anticoagulated, and they're receiving treatments so they reduce their risk of AF-related stroke, but they also improve the quality of their life because of the treatments for AF.
Yeah, I don't know if there are questions. If there are questions, you can raise your hand. There's a hand. Yeah, Marilu has a question, I believe.
Yeah. Yeah, thanks for the talk. I really appreciate also because I strongly believe in how important are communication and education. And I guess also these pandemic situations show us how important they are. And so, and also think that actually most of the researcher and clinicians don't know because nobody teach us. For example, I just finished my graduation 2 years ago, and nobody taught me how to communicate and educate, in my case, students or patients as well. So my question is, how can we avoid this situation, and which institutions should take care of how clinicians and researchers as well communicate and educate the society?
Thank you. Well, only yesterday I was on another session with ESC, and one of the things I recommended is that professional organisations, medical organisations, should be training their members, the healthcare professionals, on how to engage with clinicians. And especially, even more so now that we're digital, we're meeting on Teams and Zoom. Many patients have never had this, and often AF patients, as we know, tend to be older, and certainly in the UK, for many, they're not as au fait with digital technology and Zoom and Teams. There are ways of engaging with patients. One of the things that we've done for years, we host the Heart Rhythm Congress, that's the virtual background behind me, but we also host a patient day. It's always been physical until this year where we had to go virtual. We had over 500 AF patients register and access talks on atrial fibrillation. So we interview clinicians, we're building video libraries on all different arrhythmias, but we're focusing on AF right now because of global AF. But we think we should also start doing something similar for healthcare professionals. The reason I've pushed for it to be called AF-related stroke, which I know a lot of doctors, and I'm on the AF screening committee with Ben Friedman and Hugh Calkins and John Cam, and they refer to it now as AF-related stroke. If you say to a patient, here's your treatment for to help you against stroke, often the patients call us and say, I went in with thumping in my heart, but my doctor talked to me about something in my brain. He wasn't listening, because they don't know the connection. So something as simple as referring, this is anticoagulation therapy to help reduce your risk of an AF-related stroke, you're immediately educating that patient. And it doesn't cost any time. It's just, instead of stroke, it's AF-related stroke. And immediately the patient thinks, I need to take this medicine, otherwise I could have an AF-related stroke. They also have confidence in you. Instead of calling us and saying, my doctor wasn't listening, didn't hear what I was saying. Because, you know, a lot of patients or a lot of people do not know the connection between the heart and the brain. Why should they? They're not doctors. It may be the first time they've ever had anything in their chest. The only thing that the public know are heart attacks in many cases. And so this is why it's important we spend time. My own daughter is a doctor, and she said throughout her medical studies, there were so many, you know, obviously she knows all about arrhythmias because of my job, but she said it was such a small part of her 6-year training. And so I think that's something that needs to be done now that, you know, there's a lot of the telemedicine, a lot of, you know, appointments are online now because of COVID. It's perfect. Patients, majority of patients like the online consultation because it's like right now, you're looking at me, I'm looking at you. Patients feel that their doctors are making time and they are paying attention rather than if they're in an office, the doctor may be writing down notes or he may be looking at the screen, not looking at the patient. So for the majority, they welcome it, but they also, you know, just as we all had to have some sort of training to understand Teams or Zoom or whatever platform, remember patients need that as well. So I think it's important that professional organisations, patient professional, you know, not just healthcare professional organisations, there are a lot of professional patient organisations as well. And if we work in collaboration, which is the ethos of Arrhythmia Alliance, hence why, you know, we had over 4,000 healthcare professionals attend the Heart Rhythm Congress, which is still open, and you can access and learn from that as well if you want the link. It's free of charge, with over 70 hours of presentations and over 30 hours of presentations for patients. So there's a lot out there, but it's how to access it. And I think meetings like this are great for sharing knowledge, sharing education, and just, you know, something as simple as AF-related stroke, and it is a therapy, not a treatment. And asking the patient, what do they feel? What would they like to expect? What are they hoping to get from the appointment? And listening to that, all of that, that engages, that communicates, that encourages the patient to share what their concerns may be. I hope that helped.
Yeah,
Thanks.
thank you. And I would like to move this conversation to Felipe. He's also a clinician, and he may have a complementary point of view of how the patients do see the management of atrial fibrillation, how it affects their lives, and how they would like to be engaged on this.
Well, patients with atrial fibrillation are very concerned with when you tell them the things that they have to undergo to be treated, because most of them are going to need different drugs or approaches that they're worried about them. So you have to take time and to explain them carefully the impact of these different treatments, either drugs or ablations or even the follow-up, which can be time-consuming and costly also for them. So it's not easy. I clearly think that having a specific AFib clinic, either led by physicians or nurses, will be very helpful to take the time needed to better communicate and to better educate the patients to be treated properly. That's on one side. And on the other hand, it's also very important that we are able, physicians working in atrial fibrillation, that we are able to better educate the rest of the physicians, because as Trudy was saying, many physicians are not aware of the possibilities of treating invasively or with other strategies patients with atrial fibrillation. So it's very important to be able to communicate and also to educate physicians, general physicians and internists that are dealing with patients that have atrial fibrillation, to be able to transmit the same message, because the problem that the patient will have is that they are going to find different messages for the same disease, and that is very confusing for the patient. So the patient needs to have the same message for his disease, otherwise they will be confused. So these are my main 2 points regarding patients management.
Thank you, Felipe. And now I want to move also this same topic to Daniel. So what do you think that we as researchers in the field of atrial fibrillation should do to engage more the patients, or to make them feel more confident on the treatment that they should be receiving? So
As a researcher, I will say that now we start in to think about health literacy and how to get the patient involved into a clinical research set. So I think it's more common to have this more or less soft data, because you cannot really you can measure compliance, or you can measure it, but it's not, when you look at the journals and papers, they have to be aware about this kind of studies, getting more into social social complexities into treatments and so on. You not see this in journals or in high-ranked journals like this. So that is an issue. It is common, and you can move forward with a more social science, getting into disease. So for me, as an health scientist or public health professional, I'm aware of that, but I also see the problems, particularly in cardiovascular research. It is more, it's getting more to a basic research, how can we get in a broader picture about about MRI detection of happening. So I think it's good to have studies on point to get in more into social complexities about treatments that patients get. Yeah.
Okay, thank you. We have also questions from the audience. So Ursula,